So good evening, everyone. We're happy that you joined us tonight. And today we have, I think, a special treat, um, more than always, because it's our own Kim Chi Tran and Miles Sargent, who are going to talk about greening healthcare. And I think both are forces of nature within our community of doctors who care about climate change and are acting to do things about it. So just, I think Kim Chi was co-chair of the climate of our Green is Health Medical Interest Group. And I'll introduce Miles, who's about to be the executive director of the Coalition of Green Healthcare, and is also the co-founder of PEACH, which stands for, and I've written this down, Partnership for Environmental Action by Clinicians and Communities for Health Facilities. So with that, I'll hand it over to you to speak about greening our healthcare.
Okay, thank you very much, Gilly. And thank you, Kim Chi, for inviting me tonight. Excited to be here again. I was invited in November of, I guess it would be 21, I think. Yeah, so I've done this before. So hopefully my slides are a little different this time around, and probably a few people here who weren't here last time. So PEACH started with imagining what an ideal green health facility might look like. And this is what it might look like. Of course, there's lots of different architectural options, but this would be one of them. And as you can imagine, if you took the H off the front of this, this could be a long-term care facility. As a Hamiltonian, to me, this looks a bit like the David Braley Family Medicine Center. Could be a library, could be a university building. There's a lot of crossover. And we had a young architect help us with this, and I'll talk about the different elements within this in a minute. So PEACH, Gilly's already done this for me, Partnerships for Environmental Action for Clinicians and Communities for Health Facilities. So that is an acronym. That's what PEACH is. I imagine many of you have seen graphs like this before. This is a graph of the total amount of greenhouse gas emissions in carbon dioxide equivalents over the past few decades. In the left, it starts the bottom left corner, the black line, 1990, with what looks like about maybe 40 gigatons of CO2 produced annually in the world. And you can see the black line goes up over 3 decades, 2020. Gradually going up. The pink is futuristic mapping. What will happen if we do nothing? And that's the increase in carbon over time and the associated increase in planetary temperature. So without going through each color here, it's clear we need to follow the green line at the bottom to get to keeping our temperature under 1.5 degree, which is what the scientists feel is the critical number. So all I've done here is taken a red bold line and added it just to demonstrate this is not a straight line we're following. We need to drop down really quickly in the next 8 years. That's a 50% drop in global CO2. So we have a lot of work to do. So why is this relevant to this group tonight? It's relevant in part because Canada is one of the dirtier countries in terms of CO2 emissions. This is actually a 2017 table, and we have improved since then. So, I mean, that's the good news, but we have a long ways to go. If you look at like another cold country like Sweden is less than 1/3 of our CO2 emissions per capita. What does it have to do with healthcare? In all the wealthy nations, healthcare, the carbon footprint is typically about 5%. I've showed 2 numbers beside Canada here, 4.6, 5.1, depending on the study that you look at. Again, whether it's Asia, North America, Europe, usually around 5%, which is more than the airline industry as a share of the carbon footprint. And of course, in medicine, we're taught above all, do no harm. But in doing our jobs, we are doing harm. Because this is a climate emergency, we don't have time to develop a culture of sustainability, which would be ideal, just like having a culture of safety or a culture of EDI in your organization. It takes time to develop a culture. Obviously, we still want to do that, but we need to have a different approach. And this is the approach we took about a year and a half. Peach was just an idea, a conversation. And so we reached out to the people in the province, not just physicians, but people in the food industry, in transportation, in facilities management, all the people who are considered stars in the healthcare sector regarding sustainability. We partner with them and we've tried to create impactful projects. So back to the Ideal Green Facility. On our website, if you click on this, you can go through the 8 different categories that we've come up with, and I think I'm showing them here. So we feel that if you are going to make a carbon neutral facility, you need to go after all these different categories, and I'll go through each one of these quickly. And of course, at the bottom here, I mentioned projects and partnerships because we are all about action. Action is our middle name. So leadership, you need to have a strategy. I've highlighted a couple of hospitals here, which are leading the way. UHN has a culture of sustainability. They started this in 1999, and I understand they have as many as 700 volunteers throughout their hospital systems. CHEO has done it a slightly different way. They have set carbon targets. They are trying to decrease their total carbon by 5% per year. And they've already done 3 years of this now. And Sunnybrook created a task force almost exactly a year ago looking for leadership throughout different sectors of their hospital. And of course, like anything, you need a person who's responsible for the outcomes. One thing we did in terms of the leadership side is we created a guidebook for healthcare leaders. Kim Chi was involved with this project. There's quite a few of us involved with this project about a year ago. We were really thinking about what are potentially the top 20, 25 things you can do in terms of decreasing your carbon footprint at your hospital. And the print might be too small to read here. This is on the Peach website under Our Impact, if you do that drop down. And this is the middle of the guidebook. The big point here is that it's not just a buildings and energy venture. There's all kinds of people that need to be involved around the hospital to get to carbon zero. Choosing wisely is part of it. Education's part of it. I mean, as you know, as physicians, choosing wisely has been around for over 10 years. It was really thought of as a gatekeeping exercise and not overusing tests. But every single test has a carbon footprint. And so this does become a sustainability initiative as well. Choosing Wisely is aware of this, and we are working with them on the sustainability side of things. We also developed a project in the education side to quickly show people the difference between different things that you can do in your facility. This is different than the check boxes. Again, the check boxes, we were really going after what you might consider your top 20 items in terms of CO2 emissions. This one, if you look at the article, it's published in Healthcare Quarterly, we looked at 3 different colors of fruit: green, yellow, and orange. The orange ones are what we call the game changers. They contain over 100 tons of CO2 per year in the equivalent of a 200-bed hospital. And so what we wanted to show is that these are some of the items that you really want to go after at your facility. And some of them, as you can see, cost a lot of money at the top of the tree, like building a new building. But some of them at the bottom on the ground, like deprescribing, not only save $200,000 to $300,000 if you can deprescribe by 5%, but they also save over 100 tons of CO2. Some of the yellow fruits and the green fruits include things like EV chargers, for example, or recycling. All of these things are important, but really we need to be going after the big items and not just thinking about EV chargers. This came out in the Lancet about a year and a half ago. This blew my mind when I first saw it. because again, you can see here, and I should point out, they were looking at the carbon footprint of their entire system, their entire healthcare system. So we're talking about ambulances and dental offices and primary care, hospitals, et cetera, everything. What does that so again, this may be 5% of their total national footprint. What does that 5% look like if you break it down? At 11 o'clock in green is personal travel, which includes visitors, staff, and patients. Only 10% of the pie. You can think about how much we talk about, greening the planet. We talk about bikes and EV vehicles. Clearly, they're important. It's 10%. But what else is there? The red section here is what's inside the building. Building energy at 8 o'clock in pink, only 10% of the pie. So again, the boiler room, ventilating, surprising that it's only 10%, because it's another thing that we talk about. We talk about it at our homes and at our businesses. So what's the big piece of the pie? The blue part is supply chain, which is all the consumables, all the things that we dig out of the ground and we ship to the hospital and we use them and then we eventually throw them out. And I do always like to point out that pharmaceuticals are roughly the first 22% of this entire pie, the production of pharmaceuticals. And then you'll see pharmaceuticals again in delivery of care around 10 o'clock, anesthetic gases and MDIs. That is the actual use of the pharmaceutical. So supply chain. Kim Chi's getting sick of this one. Kim Chi's watched me do this presentation 2 or 3 times. And let me tell you, the big point of this presentation is supply chain. So I'm really going to harp on this now, okay? So as I said, supply chain is the consumables. So I like to think about a gown, a throwaway gown. All of the gowns that we use, and we all know sometimes a gown is only used for 15 seconds. You zip into a room, ask a quick question, leave, throw out the gown. The gown has to be dug out of the ground somewhere in the world, then shipped to manufacturing, shipped to packaging, shipped to the hospital, used for 15 seconds, maybe 5 minutes, then shipped to garbage. All of the things we use in our system, masks and gowns and gloves, and office desks and IT equipment and MRI machines. These are all the consumables. So we add an extra R to the 3 R's. We add refuse. You want to refuse the bad products. And so how do you do that? Well, what we've looked at is adding sustainability language to requests for proposals. So classically, RFPs consider cost and consider quality, and sustainability language has never been in there, but we're trying to change that. So we've started a green procurement working group, and there's a good chance that your hospital is involved. There's quite a few hospitals involved, the procurement leads or VPs, and we meet once a month. And we also meet with the GPOs, the group purchasing organizations like Mohawk MedBuy, Health Pro, et cetera. We also have Supply Ontario coming to the meetings now on a provincial level to look at how we can add, we're hoping for at least 10% sustainability language, which will force suppliers to make green products. We obviously learned about the journey of various things during COVID when we couldn't get things, and we're still hearing about children's acetaminophen. I think around Christmas time, that was a bit of a crisis. And this just demonstrates, this is just something you can Google on the web. This is the journey of a computer. I think this might be laptops. And there are 2 basic journeys they show here. I'm going to start with the one which begins in Chile, raw materials supplied from Chile, traveling from number 1 across to Southeast Asia, number 2, then traveling up north for further subcontracting, then traveling into China for final assembly. If it's coming to Canada, it then goes across to Mexico, number 5 for packaging and installation, and then up number 6, Canada, to the consumer. So this is the typical journey. You can see now why products had so many trouble. I mean, if there was a problem in Chile, there's a problem in Southeast Asia, it was causing problems for our supply chain, but this is the way we do things. Staying on the theme of computers, I like to point out to people, it surprises me, even people in the procurement sector don't know about this. And this has been around for 20 years. CDP stands for the Carbon Disclosure Project, which started in 2000. So if you were interested in rating companies, how would you do it? You'd probably start by asking them, what is your carbon footprint? And encouraging them to be transparent about it and to disclose it and to work on it and make it better. And so in the first year or two of CDP, there were hardly any companies globally that either wanted to share or knew what their numbers were. This is 2 years old. It says 13,000 companies. There's now over 20,000 companies. And again, staying on the computer theme, this is how some of the big computer companies rate on the CDP scoring. So HP does well, Epson at the bottom does well. Apple does well for climate, but not for water. And most of them don't report their forest scores. COP, what was it, 18? I'm losing track. We're 20. No, 28. What was it? What was the last COP, Kim Chi? The COP in Egypt in the fall. I forget which
27.
number. Okay, thank you, Gilly. I'm thinking of COP 15, which is the biodiversity one. I'm getting my numbers all mixed up. The most recent COP was thought to be a disappointment for various reasons, but there was one good thing that came out of it. And it is that the federal government of the states of the USA is the biggest buyer in the world. And they announced that starting, I think, this year, they are no longer buying from big companies unless they report through CDP. So as I said, there's already 20,000 reporting. There's going to be even more. So this is also called value-based procurement. Some do scores which include ESG, not just climate. Universities are doing this. McMaster has value-based procurement now. Municipalities do it. Corporations do it. Other health systems, the UK, as usual, they are the world leader when it comes to sustainable healthcare. They are starting to look at value-based procurement. Kaiser Permanente is ahead of the rest in the States. My point here, we all use these big international suppliers. We all need to be sending the same message to them. We want green products. This is slightly different, but certainly follows within supply chain or the 4 Rs. This is something hopeful. St. Joe's in London became the first Ontario hospital to use plant-friendly masks, which are biodegradable. There's all kinds of products like this out there now. Companies are trying harder to make green products, and we need to embrace them. So moving on to drugs and devices. I think everyone's heard now about the whole meter dose inhaler thing, that it's a 290-kilometer car ride for each inhaler, and DPIs are better. Anesthetic gases, desflurane, 2,200 times worse than other anesthetic gases. It's now banned, I think, in 6 hospitals in Ontario, and there's a lot of other hospitals that are restricting its use. The big thing, because of what we just saw above, is prescribing less meds. We've been de-prescribing for years as physicians for good reasons. So Peach has brought together de-prescribing networks. This can't help but be a national project because the de-prescribing networks like deprescribing.ca, Therapeutics Initiative in BC, these are often national groups. So we are trying to re-energize de-prescribing from a green lens. More about supply chain. This is the journey of a pill. I found online something called pharmacompass.com, which is where the big companies buy their products from. We learn in medical school about the active pharmaceutical ingredients, the APIs, and this is one of the benzodiazepines, and it has a couple of APIs in it, but it also has between 5 to 9 excipients, depending on which generic company you're buying from. Of course, I took the names of the companies off here. I've just called them A, B, C, D. You can see all the different types of excipients you can choose from. And you go down each column, you can see in column A, that company uses 6 excipients. And I think D, I can't actually see it on my screen right now. I think it uses 9. Which process is the greenest? We don't know, but we need to know. Buildings and energy, this is a classic one. As I showed you, it's now 10%. I have a feeling it was a much bigger piece of the pie in the past, but thanks to all the engineering advancements, this thing has gotten smaller. There still are things that we can do, like decreasing the amount of times that we ventilate the operating room overnight when it's not being used. And looking at actually the fact that we have an aging population, we're building so many new long-term care facilities. You've probably heard of LEED Silver as an architectural rating for a building. You can do LEED Platinum, you can go beyond that. We need to push for that in our facilities. Plant-rich menus and decreasing food waste globally. If we forget about healthcare for a minute and forget about Canada for a minute, but globally, plant-rich menus and food waste are the two biggest things that are thought to be things that we can gain in the world in the next 30 years to decrease CO2. And it applies to healthcare as well. They're not the two biggest in healthcare, but we do need to move to plant-rich menus. We have a webinar about this in partnership with these other organizations, Nourish, the Coalition, and Cascades, next week, January 31st at noon. This is why plant-rich diets are important. This is the carbon footprint of various foods per serving. So beef is at the top, significantly higher than some of the other dairy products, and much, much higher than vegetables, which hardly have any carbon footprint at all. It used to be that bike-friendly facility was sort of the highest order of things that you could do to green your transportation, but the only problem with that is that patients don't typically bike. It's typically the doc, and if I could be cynical, it's the anesthetist who's biking to work and then using desk flooring. Virtual medicine has now become the highest thing that you can do because no one's traveling. So we need to continue doing virtual medicine. We need to find ways of doing it safely. And one other point to make. Conferences. This is a conference, I believe this one was in England. It was a pharmaceutical conference, and someone looked at the carbon footprint of staying at home and doing the virtual conference. That's the green stuff on the right. The use of internet and the office over a weekend in kilograms of CO2 adds up to 10. And then flying to the conference for the weekend, using the taxi, taking the plane, hotel, etc. Clearly, the plane is the big one. So what I say here, we're probably not going to stop flying, but we do need to advocate to continue to have the virtual option at conferences. And finally, trees. I'm still part of an organization called Trees for Hamilton. We plant trees at health facilities. We spread this idea around Ontario by partnering with some of these big groups like Forest Ontario, Landscape Ontario, Ontario Parks, etc. And we launched a project in September at a group of hospitals in Ontario with the goal of planting over 800,000 trees in the next year at or near health facilities in Ontario. And this will become a national project pretty soon. This is a new one for kimchi, so I'm happy about that. It's terrible. I really don't have a steady hand. I must have had coffee. But what I want to show here, Peach has spent a lot of time on hospitals and long-term care facilities in the last year, and basically I'm showing you why. This is Australian data looking at CO2 equivalents in hospitals. So the hospital is a total of 44% between their public and private, and the clinics, general practice 4%, specialists 6%. Again, everything's important, but this is why we've really been harping on the hospitals in the last year or so. So what about your clinic? Well, this is primary care. I'm going to leave the specialist stuff to Kim Chi. Can't even remember, did I mention I'm a family doctor in Hamilton? Although I do mainly secondary care, but nonetheless, this is that same UK data. If you dig into it a little further, one of the Peach students that works with us, I asked her to make a nice little pie graph of just the primary care piece. And so this is what primary care looks like. And you can see that pharmaceutical piece actually moves from 22% overall, because now we're not talking about dentist offices, ambulances, and specialists and hospitals. This is primary care. Primary care, 48% is medications. 48% is the production of the pharmaceuticals. And then there's another 13%, which is MDI use. So it's really mainly about the meds. I mean, if I could really harp on this one for a while, Kim-Chi, it just kind of blows your mind. Because if you look at building energy and water and waste, which is red, I mean, you almost wonder, like, we have solar panels on our farm, but at your office, it's all about deprescribing. So our approach to primary care clinics, of course, you want to prevent disease and prevent hospitalization. You want to deprescribe where appropriate, switch from MDIs to DPIs, refuse bad products of all kinds. If you can use things which are reusable, I mean, there's all kinds of masks out there now, which, you can use for up to a year sort of thing. Finding the best companies, supporting the best companies by looking at things like cdp.net, and obviously educating people about plant-rich diets and active transport. Here are some of the specific things in a clinic. You can reduce use of gloves. I mean, there's some evidence out there now that maybe we don't need to be using gloves as much as we do. The reusables, speculums, masks, patient drapes, and recycling, again, is the last of the 4 R's. So recycling is important, but you want to be higher up in the chain. So who's responsible for climate action? Ultimately, no one in our society really is. And so that's a big part of the problem. I would argue that we all are. Ontario is such a big province, 650 long-term care facilities, 350 hospitals, 1,000 buildings, big buildings, plus all the offices. We need thousands of climate action champions. There's so much you can do. And Kim-Chi is a climate action champion. So I'm going to pass it over to Kim-Chi now. I think I'm going to have to stop sharing. Take it away.
Thank you so much. All right. Let me share my screen with everybody. All right, I hope everyone can see my screen. So I'm going to talk more about the sort of hospital environment, and starting off with, how do we actually score a medical facility? The first thing I'd like to talk about is that we're not quite comparing apples and oranges, or apples to apples. We're comparing apples to oranges here. And the reason for that is because Canada has a wealth of different types of energy or sources of energy. So what I've circled here on that pie chart, and this is taken off of the Canada Energy Regulator, I've circled all the bad polluting ways of producing energy. So things like natural gas, coal, coke, and petroleum. So we see that unfortunately this still makes up part of our energy grid. So what does that mean? When we take a look at our energy sources itself, and we break it up in terms of provinces and territories, we see that the CO2 emissions vary greatly from place to place. So this first example is of Nunavut. So Nunavut has the highest amount of emissions for the energy that they produce. And if we look at why, you can see from the pie chart, it's made entirely, or it's from entirely made out of petroleum. And so you can see why using energy in Nunavut is going to be more polluting than elsewhere. I want to contrast this now with Quebec. You can see that Quebec has lower CO2 emissions for the amount of energy that they produce. And the reason for this is because most of their energy is clean energy. So most of it comes from hydro. There are a lot of waterfalls in Quebec, and they definitely gather their energy from there. And a lot of it comes from wind as well. So you have not very polluting sources of energy. So what does this mean? What this does mean is that if you light a light bulb in Nunavut and you compare it to the exact same light bulb, but in Quebec, they're going to have completely different carbon footprints in terms of when you turn on that light. So this plays a role in terms of figuring out healthcare emissions and facility emissions, because really a lot of this depends on where you're located. And the same thing is true of supply chain and products. So it depends on where things are made, what type of energy, what kind of carbon footprint, embedded carbon is in that product. I did also want to show you Ontario's carbon CO2 emissions for energy that we produce. And you can see that on this table, we are fairly low down in terms of being a fairly clean system. The issue here is if you look at our pie graph, 59% of our energy comes from nuclear. And so why this is important is because the current provincial government does plan to phase out nuclear. So the Pickering Power Plant is supposed to be shut down in 2026 because the costs for refurbishing are quite high. And so those are the plans now for it. And the government does plan to replace it with natural gas instead. So as you can imagine, this is going to change our emissions profile quite a bit. So how do we actually look at healthcare emissions? How we do this is we break it up into 3 different categories. So the first category that you can see, Scope 1, these are the emissions that are emitted directly by the healthcare organization itself. And this is represented by the light teal bars on the graph to your right-hand side. So these are things like the boiler room emissions, inhalational gases, anesthetic gases, those sort of things. So what is the actual facility itself emitting? Scope 2 is the energy grid. So what is their energy grid like? Is it clean energy? Is it fossil fuel energy? So that comprises Scope 2, and that is sort of the medium shade of teal on the bars. Scope 3 represents the emissions emitted in the supply chain. So as Miles mentioned a few times in his presentation, the supply chain is a big player. In fact, if we look at it throughout the years, it's about consistently 80% of your total healthcare emissions. Taking a look at NHS, so again, as mentioned, the United Kingdom is always a lead player in sustainability. And so how they've grouped their emissions is that they've put together Scope 1, 2, and 3 emissions that the facility actually has direct control over. And they've set a target to reach net zero by 2040 for these emissions. The other things that they do not have as much control over, for example, where they source supplies, patients and visitors traveling into their hospital, they can make suggestions and recommendations, but they've also put a net zero target on this for 2045. So I think this is very inspiring, and this is a very interesting way at looking at how we can sort of categorize our scopes, our emissions, and how we can try to reduce these emissions. Taking it a little bit closer to home here in Ontario. So CHEO takes into consideration scopes 1 and 2. The issue is because, as mentioned here in Canada, we don't have a great idea of what our supply chain footprint is. And again, this is something that will hopefully change in the future. But CHEO is focusing on the things that they can track and they can change now. And you can see from the very bottom sort of navy blue section with the big red arrow, it looks like they're on track and they're actually doing a little bit better than projected in terms of reducing their carbon footprint. So this is sort of reassuring, and it's nice to sort of see action in our own backyards. Knowing all of this, how can we get leadership on board? I think the tricky thing with healthcare facilities is that one person can't really change things. We need a whole team to get on board. So what I propose here is that you go to the leadership and you tell them about all the benefits and why they should do it. So first off, financial savings. Everybody needs to save money. It is a public funded system after all. We also want to enhance the brand. So hospitals have a brand that they sort of show and display to the public, and we want our patients to know we are modern, we understand what challenges health nowadays. And so being on board with climate change could only enhance how the public perceives your hospital. We also want a resilient healthcare system. We want a healthy workplace. And then, of course, why are we tackling climate change in the first place? So first off, as I mentioned, we want to follow the money. It makes sense that using less spends less. So as mentioned, we want to de-prescribe medications. The less medications we prescribe, the less we're going to take out from that supply chain and the less of a footprint we're going to create. We want to be using more reusable items, for example, reusable gowns. At UHN's University Health Network, downtown Toronto, they found that there was a 60% cost reduction in using reusable gowns. So it's almost like a no-brainer. It makes so much sense. It's good for the environment and it's good for the pocketbook. And then lastly, OR pick list streamlining. So there have been studies that have shown that up to 87% of items that are used in the that are picked in the operating room are actually not used. So there's a lot of waste. I actually spoke with our facilities manager this afternoon, and they're actually finding that even on the floors in patient rooms, oftentimes when patients have contact or isolation issues, the second that patients discharge from hospital, they have to throw out everything that's in that room for fear of contamination. So these are things that we can definitely improve upon, and would lead to immediate cost savings. Within the organization itself, it makes sense to hire an energy manager or leader. This is estimated to cost about $110,000 per year. But in doing so, we're reducing emissions, we're reducing waste, and waste is not free. We have to pay for waste in terms of trash and recycling. And so we do need to reduce waste, and also future carbon tax increases. So I believe right now the carbon tax is at $50 per ton of CO2, and that's projected to increase to, I believe, $170 per ton of CO2. So if we can save the amount of carbon, then we can save that amount of money as well. So moving on to brand optics. So this is a neat sort of cartoon depiction of the different trends of or the different themes of what people think when you mention climate change. This is based on a study done out of Yale, and it's called the 6 Americas. So the first person, the alarmed person, realizes that climate change is real and that it's imminent and that we need policy change and we need to act quickly. The second category is the concern category. So they believe that climate change is real, but they think we might have a little bit of time and it's not that imminent. The cautious people, they're not really sure if climate change is real, if it's a bad thing or not. Disengaged people have no idea about climate change at all. Those who are doubtful think that this is just sort of a natural sort of cycle of CO2 and that it's nothing out of the ordinary. And then unfortunately, we have the dismissive people, the people who think that climate change is merely a hoax and it's not real and everything's going to be okay. So why this matters is that in their study, they looked at these different categories and they looked at the percentage of the American population who fit into each one of these categories. So just to remind you, the alarmed and the concerned groups, those were the two groups that believed in climate change and thought that it was an issue. So as you can see, from 2017 to 2021, the amount of people who are believing in climate change and the amount of people who are alarmed about climate change, that's increasing. So this is good news. When we take a look at the Toronto Academic Health Science Network, which is a large network composed of most of the Toronto area hospitals, they polled the workers of the hospital. So this includes physicians, nurses, allied health, support tech, and they found that 96% of employees agreed that healthcare actually plays a very important role in reducing environmental harms, and that this is something that we should do. So what this shows us is that we have staff buy-in. The 6 Americas show that we have patient buy-in. And so this can lead to some fundraising. So a hospital can say, you know what, these are the green initiatives that we're supporting. If you can support us, we can support these initiatives. So that could be an angle that they can take. And of course, hopefully not greenwashing, but actually following through with these sustainable actions. The next thing I'd like to talk to you about is facility adaptability and resilience. So this is a really neat bridge that I came across in one of my online web searches late at night. And this is a bridge in India that was formed by the indigenous peoples who live there. So this bridge is in the wettest part of the world. They are exposed to floods and monsoons, and they found that man-made bridges were just not cutting it. So what these indigenous people did was they actually trained these rubber fig trees to grow along as a bridge, and then they let these trees grow for about 10 to 20 years. Obviously, the bridges in this picture are much older than that. But after 10 to 20 years, they found that they were able to cross these trees. And the neat thing was, because they were working with their ecosystem, they were able to develop a bridge that did not get washed away, that would persist and last and be reliable for them with their extremely wet weather. Why this is important is because we know that climate change is happening. We have extreme weather conditions now. We also know that this is going to get worse. So the picture on the left is of PPE. So if I could take you back to March 2020, we all remember the PPE shortages. We remember not having enough gloves, not having enough masks. We need to make sure this doesn't happen again. So first off, what we recommend is that all facilities have a geographic assessment. So is your hospital or a healthcare facility, where are you located? Are you prone to flooding? Are you prone to earthquakes, tornadoes? What sort of resiliency do you have in place? Have you worked with your local public health team? Have you done any training with your staff in order to prepare them for sort of mass casualty events or extreme weather events? We need to do a vulnerability assessment as well. So which populations are at greatest danger for having issues? So for example, extreme weather events. What is the homeless population like? What are the elderly? What are the children like? So, and how are we going to help treat them? So these are things that we need to figure out and plan for now, because we do know that it's coming. In terms of promoting sustainability within the hospital system, this also leads to a more healthy workplace. So this was a really neat study done in 2014 where they studied ICU nurses, and they had ICU nurses who normally didn't get much daylight in their system, and they just gave them a window. And they found that those who had more access to daylight, they actually reduced their blood pressure, increased their temperature, improved their communication, their mood, decreased their sleepiness, and non-significantly, they also found that medication errors decreased. So it's good for us to be in touch with nature. It's good for us to have healthier workplaces. As Miles touched upon, plant-based diets also come to mind when we talk about a more sustainable and healthy workplace. And as we all know, the Canadian Food Guide has changed and is now recommending more plant-based proteins. And this leads to a wealth of benefits such as reducing body mass index, reducing blood glucose, decreasing inflammation, blood pressure. So it's healthy for everyone, and it's good for the environment. Lastly, I want to turn your attention to this TED Talk from 2021. I recommend that you watch it. It's very short. It's like 8 minutes or something. And it's entitled, "It's Impossible to Have Healthy People on a Sick Planet." And this was done by Shweta Narayan. And this was such an engaging and compelling title because I believe that it's true. It's impossible for any one of us to be healthy if we're living in a sick or polluted environment, or an environment that can't help sustain us. So as we all know, when we become doctors, we have a white coat ceremony. Pharmacists, dentists have a similar ceremony. And that white coat is actually a symbol. The coat itself being put on our shoulders is the same thing as responsibility being put on our shoulders. This is something that we take with us throughout our lives afterwards, the responsibility that we carry towards our patients. And so really, if we're going to be responsible health practitioners, we really need to be thinking about climate change, how to mitigate it, as well as how to adapt to meet the challenge. And with that, thank you so much. I'm going to stop my sharing here. And Gilly, I'll turn it back to you.
Thank you. So it's 9:30 already. I don't know if people have more questions, or would you like to wrap up? So I think we'll wrap up. Thank you so much, Miles and Kimchi. I learned a lot, and I'm looking forward to watching this again, the recording, and picking out things from there that I'm going to use. Thank you so much.
Yep. Thanks for having us. Yeah. Nice to see you too, Ellie and Adrian.